We will begin our session in about a minute. So I can see a lot of people joining us right now. This is the educational session titled Advancing Pediatric Acute Lymphoblastic Leukemia Care, Adapting Global Standards for Low and Middle Income Countries. During the presentations, we kindly ask all participants to remain on mute. If you have any questions at any point, please enter them into the Q&A box, and we will address them during the discussion period. So, my name is Praploy Monsilapachai, and I am honored to serve as today's moderator for this session. This is the second session in our SIOP Asia Educational Session series, and we are delighted to see colleagues returning, as well as new participants joining us. Through this series, our aim is to build a practical and collaborative platform that supports the strengthening of pediatric oncology care across the region. Our focus today is advancing pediatric ALL care. While survival outcomes for childhood ALL have improved dramatically worldwide, resource limitations continue to create significant disparities. Today's session aims to bring together global expertise and regional insights to explore how evidence-based ALL care can be adapted sustainably and effectively across diverse settings. It is a privilege to begin with an exceptional keynote speaker. It is a great honor to introduce Professor Hiroto Inaba. Dr. Inaba is a faculty member in the Leukemia Lymphoma Division of the Department of Oncology at St. Jude Children's Research Hospital, where he also serves as the director of the Pediatric Hematology Oncology Fellowship Program. He is a globally recognized leader in pediatric leukemia, dedicated to advancing comprehensive therapies and transforming care standards worldwide. Dr. Inaba also served as chair of the NCCN guideline for pediatric acute lymphoblastic leukemia, underscoring his significant influence on international clinical practice. Professor Inaba, thank you so much for joining us. The floor is yours.
Thank you for kind introduction. I'm gonna start my slides. Just a moment. Okay, let's start. Okay, so this is leukemia cells, and it is about 20 to 25% of pediatric cancer. And then what I talk may not happen immediately, but I'm hoping it's gonna happen soon. So I show the history of St. Jude, 1960s. Survival was terrible. Only at that time, only a small number of the patients survived. And then leukemia relapse in bone marrow, not only that, and they relapse to sanctuary area like CNS and testis. And then 1970s, survival improved to 50% or 40% and because of the cranial irradiation. This is a unique therapy at that time, but we noticed that this is associated with a neurocognitive deficit, endocrinopathies, growth and sex hormones, and the secondary malignancies, and excess rate mortality, and decreased quality of life. And since you try to remove this cranial irradiation while improving the chemotherapy combination and doses. And then at that time, for those patients who got the radiation, had some deaths 30, 40 years ago, 40 years later, because of the side effect from cranial irradiation or some other chemotherapy. So we removed cranial irradiation to change to intrathecal therapy. And then survival now in St. Jude, we are achieving 94%. Cranial irradiation was gradually removed to have better risk classification, intrathecal chemotherapy, and a better combination chemotherapy. However, in high-income countries, we are hitting the limit. We are not able to go to above 94% in the last 20 years. There's a limitation in the conventional chemotherapy if we want to go more. The therapy given in the high-income countries is very intense, still intense, to cause hair loss, mouth sores, infections, and now in the high-income countries, we use pegylated asparaginase, which cause pancreatitis and thrombosis. And not only that, survivors suffer from many toxicities, secondary cancers, cardiovascular disease, neuropathies, or obesity, or many other side effects are there. So we need to make it better in high-income countries, which also, should happen in the low medium-income countries. We need a better risk classification and then new therapeutic approaches. As you see here, red means low survival for the cancer, pediatric cancer. Green is higher chance of survival. As you see, there's a discrepancy or inequality between the high-income countries, middle and low-income countries in terms of survival. In the acute lymphoblastic leukemia, high-income countries are achieving about 90% or higher. However, only 15% population live in the high-income countries. In the low-medium-income country, where 85% population live, survival is only at most around 50%. There's a big difference. Also, strong chemotherapy will not work in the LMICs because they have many issues to overcome. They tend to have a delayed visit and diagnosis. They come with a malnutrition and infections. There's many countries do not have a medical insurance, and treatment cost is very high for the house income. And then there's the issue about treatment adherence and abandonment. And then some countries lack chemotherapy agents, and then insufficient supportive care, and also very limited number of specialists, lack of specialists. So we need to overcome these issues, but these issues, we need to go one by one. But I'm telling today is what can be applied done in the high-income country to LMICs. So we use risk classification for three major factors. Clinical factors, age 1.9.9 is better than less than 1 or 10 years or higher. WBC count less than 50 is better than 50 or higher. And the immunophenotype B is better than T. And the extramedullary disease, CNS, testicular involvement, has tend to be worse outcomes. And also now we use genetic analysis, starting from cytogenetics, FISH, RT-PCR, and next generation sequence, which is done in high-income countries now. And then response to therapy is important. Minimal or measurable residual disease can be done flow cytometry or PCR or next generation sequencing. So critical factor is relatively obvious, but genetic analysis is done this way. We take the sample from the normal tissue, such as skin or remission blood, and this can tell us disease predisposition or cancer predisposition, or we can use for drug metabolism, such as TPMT or NUDT15, that metabolize 6MP, because everybody has different futures. Germline explain that kind of futures, at least partly. By comparing leukemia and germline genes, we can identify leukemia-specific unique changes, which are expressed by these digital karyotyping, variants, SNBs indel, and copy number changes. Now, we can identify in high-income countries ALL to more than 15 subtypes. ETB6 ranks 1, high hyperdiploid is very good prognosis compared to BCL1 or BCL1-like. So low medium countries, I suggest that at least if you go into genetics, we should identify ETB6 ranks 1 by FISH and RT-PCR and high hyperdiploid by DNA index and FISH and cytogenetics. ETB6 ranks 1 is so cryptic, small translocation. Therefore, we cannot detect in cytogenetics. But these are important because they have very good outcomes. Also, if you can identify BCL1, which is detected by FISH, cytogenetic, and RT-PCR, this is important because we can use the tyrosine kinase inhibitors. Now, also, Centrojude is developing low-cost nanopore messenger RNA sequencing, getting RNA and then make a cDNA and put into this small machine, and this machine analyze the sequencing. And then, for example, B-cell leukemia can be divided by ETB6-1 hyperdiploid and pH. This subtype can be identified in the inexpensive way. So Centrojude is developing in several countries to diagnose leukemia using this. Minimal residual disease is very important because when we use a microscope, my eye can detect about 5% of blast, but MRD can go much lower level to detect leftover leukemia. Not only sensitive, also specific. This is the diagnosis. You see a lot of leukemia cells. If you give chemotherapy, bone marrow go down and come up. At that time, you see these kind of blastic, large cell. All time, we couldn't tell this is a leukemia cell or normal progenitor cells, hematopoietic cells. And in this patient, MRD was negative. So most likely these are normal baby cells, hematopoietic cells. So microscope may not be accurate actually in the diagnosis. So MRD use unique phenotypes of leukemia. Flow cytometry can detect the aberrant phenotype that can go to 1 out of 10,000, and PCR immunoglobulin T cell receptor rearrangement and fusions that can go down to 1 out of 100,000. And next generation sequence can go to 1 out of 1 million. In low medium income countries, Centrojude developed MRD Lite, which only use 3 markers, CD10, 19, and or 34 on day 15. CD10 plus CD19 double positive cells usually go away after steroid is given for 2 weeks in the healthy people. So in this patient, no MRD, nothing CD10, CD19 positive. However, on day 15, if these cells are present, we consider this is the leftover leukemia cells resistant to steroid. And then Centrojude group compared official conventional flow cytometry MRD and this easy MRD, right? It's highly correlate. And also, if positive, it can predict refractory or relapse disease. So in Brazil, by combining these factors, very low, 25% of pediatric ALL is highly curable, 97.3%. If you can identify age, which is not difficult, and WBC, and DNA index by flow cytometry, 1.16 or higher, and then ATB6 ranks 1, which is important and a good risk factor, and CNS 1 and 2, no testicular disease, and MRD Lite on day 15 is less than 0.01%, which is a very curable. So we do not have to intensify therapy. And I think we have to focus these population if we have these capability because they can survive in high possibility. So I think we need to improve because other patients, we need an intensive therapy. But low LMICs, it can be difficult. It might be too intensive. So conventional chemotherapy we're using is approved before 1980s in the United States. And then intensive conventional chemotherapy is now raised to the limit of tolerance. If you increase the chemotherapy, just increase the toxicity, we cannot go the survival higher. This is true in the LMICs. We got to use new medications such as molecular target therapy, imatinib, dasatinib, ponatinib, and then immunotherapy, blinatumomab, CAR T cells, inotuzumab. Molecular target therapy attack the gene abnormality and block the activity of the gene. Very famous example is a BCL-ABL1 positive ALL, which is chromosome 9 and 22 are fused, make a BCR-ABL1. This BCR-ABL1 bind to ADP and ATP, and leukemia become aggressive. But by giving imatinib or some TKI, ADP doesn't bind here, and leukemia activity decrease, and then chemotherapy can kill the leukemia. So this is adult Ph positive leukemia, which used to be deadly disease until 2000, and they start using chemotherapy, hyper-CBAT plus imatinib, then dasatinib second generation, and ponatinib. But the adults are slightly sensitive to chemotherapy. Some die from toxicity, so they stop chemotherapy. Blinatumomab plus ponatinib combination can cure the outcome survival to 94%, which is a very similar curve as I just showed in the St. Jude ALL rate. So adults are now treating Ph positive ALL like a chemo-free chemo-free regimen. Immunotherapy is also important. Bispecific antibody blinatumomab, and then chimeric antigen receptor T cells, and then antibody drug conjugate, inotuzumab ozogamicin. I talk about blinatumomab for now, and the blinatumomab is a CD3 antibody, and CD19 antibodies are conjugated, and T cell bind to CD3 site, and then B cell and BALL cell bind to CD19 site, and T cell attack the B cells and kill it. This has a unique side effect, and then such as cytokine release syndrome, because cytokine release a lot, onset day 2 to 5, fever, hypoxia, hypotension, and then we treat with the tocilizumab or steroid. Also, cytokine also induced immune effector cell-associated neurotoxicity syndrome, ICANS, onset days 7 to 9, and altered mental status, tremor. We use a dexamethasone and anti-epileptics, and then this is a high risk especially in the Down syndrome. So Brina is changing the game, changing the treatment strategy of the acute lymphoblastic leukemia. In the infant leukemia, blinatumomab was added to the Interfund 06. Only one blinatumomab addition made the outcome 65.8% conventional, historical, to 93.3%. Also, NCI standardized patients as an overall cohort, 96% and 87.9%. Brina improved significantly disease-free survival. And among these, patients who had average relapse risk, high relapse risk, both improved outcome. This was due to the decrease of isolated bone marrow relapse in the blinatumomab arm, and then in the both arm, in the randomized study of blinatumomab versus control arm, CNS relapse was not different. So we consider that activity of CNS of the blinatumomab is limited. So we had to give a good intrathecal therapy with the blinatumomab. In the high-income country, especially USA, we have proven that infant work after 1 cycle after 1A, NCI standard is 2 cycle after consolidation, then interim maintenance 1, and adult 4 cycle after intensification. All the study improved outcome. We don't have a strong evidence in NCI high risk in the randomized setting, but we think all the patients with the B-cell leukemia, except maybe very low risk group, very benefit from the blinatumomab administration. So these molecular target therapy, immunotherapy, decrease the chemotherapy and remove the chemotherapy by giving this specific therapy. One example shown in the 60 years old or higher, we are learning from adult a lot. Ph negative B-cell leukemia, they added imatinib to the low intensity chemotherapy, followed by blinatumomab 4 courses, and then blinatumomab to the maintenance. Outcomes improved to 34% and 64%. These patients cannot handle strong therapy. So I thought that blinatumomab should be delivered to LMICs before the COVID. And before the COVID, actually, I truly directly called Amgen whether they can donate blinatumomab, and they agreed. And then we tied up Central Global and local sites, and then Direct Relief, which is the NGO that bring the blinatumomab to the countries, and then also individual institution with a cold chain. We started from India, Pakistan, Vietnam, now expanding to Egypt and Paraguay. And then this is the first patient who are treated in India. Lastly, blinatumomab is very attractive. And I hope it become available in everywhere, but not yet. Only we are doing this, program. But these, still need improvement. Patient need to carry the bag or need to be inpatient for the continuous infusions. Now, subcutaneous blinatumomab become available, and a pediatric study starts soon. In this setting, this is the adult data. Only subcutaneous blinatumomab for patient who got a transplant, patient who did not go to transplant, they had excellent 1 year survival, or 80% who received a transplant, and who did not go to transplant, 85%. So blinatumomab may bring the cure for the patient who relapse, and then by giving subQ blina in the high dose, no transplant can survive. Now, last 10 years and next 5 years, we are seeing the dramatic change in the treatment strategies. Not only molecular target agent, many immunotherapy are going to come. So eventually, these treatments come to LMICs, hopefully improve outcomes. As a summary, the survival area significantly improved in high-income countries. Risk-based therapy using clinical, genetic, and MRD factors. The intensive conventional chemotherapy is raised to limit. So we have a remarkable development of new therapeutic strategies, molecular target therapy and immunotherapy, that we need to think globally and collaborate. There is a big difference between the high and low medium income countries, and a better diagnosis strategy and disease evaluation is going on. And then if, collaboration of the company and the countries and St. Jude and other, high income countries, hopefully we can bring these new agents, and we can replace chemotherapy with a molecular target therapy and immunotherapy to decrease the intensity while improving the outcome and decrease the side effect. Thank you very much.
Thank you so much, Professor Inaba, for an exceptional presentation that beautifully integrated global evidence, survival advances, toxicity considerations, and the practical realities of delivering ALL care in resource-limited settings. We will now transition to our regional perspective segment. To begin, I would like to invite Dr. Nguyen, Chair of the Vietnam Pediatric Oncology Association, to offer a brief preface framing today's regional challenges and opportunities in pediatric ALL. Dr.
Yeah,
Lan,
thank
please.
you. Yeah, thank you so much. And today I would like to introduce the Vietnam Pediatric Oncology Association. Next slide, please. Our Vietnam Pediatric Oncology Association established in 2010, supporting by Loan Vietnam Childhood Cancer Program. Our organization holds election of the executive committee every 5 years. And our executive committee now is including 19 members and an advisor. Our advisor is Professor Nguyen, and we have a 3 vice chair of the is a member of the biggest hospital in Vietnam. Our organization have a representative of almost big hospital for children and for cancer or in hematology hospital. And Dr. Hoa is now is the SIOP ASEAN country ambassador. Next slide, please. And this map is our hospital own hospital in Vietnam. In north of Vietnam, we have 6 hospital and center in 3 hospital, and south is 5 hospital. Take care children is the cancer, and almost the hospital in the under the government. Excuse me. And almost the hospital in the take care children is the ALL. We have only one private hospital. Next slide, please. Pediatric oncology in Vietnam is play the important role to run the activity of Vietnam Pediatric Oncology to strengthen networking and collaboration. We hold 1 or 2 national meetings every year. We discuss the strategy of prosperity. We hold a lot of the in-person or virtual training to provide knowledge for medical staff of our own hospital. We receive a lot of support by Sengzut team, ASEAN Pacific Alliance, and Curie Institute team. We consulted a lot of difficult case through the TV Zoom board meeting, online or email. We translate the pediatric hematology oncology handbook into Vietnamese, and we delivery free for all young doctor. All hospital publish a lot of article in Vietnam or international journal. We organize annual pediatric oncology conference in Hue. We receive a lot of support from Sengzut. They contribute and bring the valuable opportunity to the pediatric oncology in Vietnam with the global initiative. For example, in the we receive blinatumab donate from the program Sengzut and Amgen for the patient with ALL. And that's all. Thank you for attention.
Thank you so much, Dr. Lan, for the clear and compelling introduction. Our next speaker is Dr. Nguyen T. Kim Hoa, SIOP Asia Country Ambassador for Vietnam. Dr. Hoa will share Vietnam's experience implementing evidence-based ALL practices in resource-limited settings. Dr. Hoa, the screen is yours.
Good evening and good morning, everyone. Now I would like to share about ALL treatment in Vietnam. So my presentation have a 4 part. So for the situation of treatment in Vietnam, we are facing many difficulties such as insurance only cover 80% for children over 6 years old. For transplantation, insurance only cover partial and the cost is expensive. And some patients, at the initial time, if they don't go to public hospital, normally they don't have a standard treatment, only palliative care. And for medicine, a shortage of medicine sometimes happens such as vancomycin, methotrexate, MB, and asparagine. And for genetic test, we can do the basic genetic test such as BCR APL1, TLAM1, E2A, PPH1, and MLA for AF4. At some hospital, due to insurance, sometimes doesn't cover. And for pharmacogenetic test, NUDT 15 and TPMT, we can be done at a few hospitals. And for relapse ALL, we have a blinatumab which is bought from Central Children's Research Hospital. And for transplant, we have a limitation because TBI is not available in public hospital in Vietnam, and also the cost for transportation and lodging. We don't have a house for our patients except one house at Children's Cities Hospital, and some ethnic patients who live far from hospital face challenges with transportation and finding a place to stay. And for number of new patients per year, we have around 575 to 658 new cases per year. We only have 3 hospitals can do transplant if patient relapse. And one hospital in Vietnam, this is Prof from Central. And for protocol, currently we don't have a unified protocol for the entire country. The most common protocol is CORI and also different between other hospital. And some the hospital, PTS and blood transfusion hospital in Hanoi, they use Prang protocol, 2000 protocol. And for Đà Nẵng Cancer Hospital, they use PFM protocol. And for survival rate, we don't have the unit research in whole country, so the data from some hospitals. So for standard risk, the survival, overall survival range from 76 to 84. And for high risk, it range from 59 to 68%. And for even free survival, it range from for standard risk, it range from 70 to 74, and for high risk, it range from 65 to 68%. And now I would like to present one report from my hospital. We do the research for genetic abnormality in the diagnosis and treatment of childhood ALL at the Central Hospital. We would like to investigate the correlation between gene abnormality and the treatment result of childhood ALL. We do the research in 83 children with new ALL. Yeah. And it's a descriptive post-static study. And I skip for clinical and paraclinical, and I move to genetic test. So for determine genetic abnormality in ALL, we find out 22.1% patients with genetic abnormality, and with the following tell AML1 accounted for the largest percentage, 12.1%, and for BCR-ABL1 accounted for 8.4%. And we also prognosis group according to genetic mutation. So we have a good prognosis accounted for 12.1%, and poor prognosis accounted for 7.2%. And for pharmacogenetic variant, we find out 80.1 patients with NUDT 15 polymorphism, and the genotype NUDT 15 star 1 accounted the largest percent, 81.9%. And for the TBMT, we find out 6.9 patients with TBMT polymorphism. And based on TBMT and NUDT 15, we can find out CMP metabolism based on patient, and we can guide the dose. And I move to the correlation between genetic abnormality and the rate of remission, relapse, and overall survival. So we find out the rate of remission variant between different group, and the different group statistically significant. And for the rate of remission based on morphology or MRD, we find out it's different. And also for relapse rates, we also find out for poor prognosis, we have a high relapse, and for good prognosis in our study during 5 years, 3 years we don't have any relapse. And for overall survival curves and even free survival curves, we also find out the difference between different groups, and the different groups statistically significant. For good prognosis 3-year survival is 100%. However, for intermediate risk group, it range from 76%, and for poor prognosis is 25%. And for even free survival for poor prognosis for 2 years is 0%. So we find out genetic tests help us to classify and prognosis childhood ALL, and finding NUDT 15 and TBMT polymorphism guide sit and below for patients. Yeah, thank you so much for listening my presentation.
Thank you so much, Dr. Ho, for that excellent presentation. Your detailed breakdown of protocols, survival results across different regions, and the impressive genetic research initiatives at Hughes Central Hospital provides a very valuable picture of Vietnam's efforts to advance pediatric ALL care. Our next presentation will be from Dr. Ganda Ilmana, representing Indonesia. Dr. Ilmana will highlight Indonesia's real-world adaptations, practical challenges, and strategies for delivering effective ALL care across diverse resource environments. Dr. Ilmana, please proceed.
Yeah, thank you. Good morning, good evening, everyone. Thank you for the opportunity. On behalf of Indonesian Pediatric Hemato-Oncology Working Group, I would like to share the overview of pediatric ALL in Indonesia, the current situation, protocol implementation, and future direction. So Indonesia as the fourth most populous country with approximately 280 million people and roughly 84 million children. This big number is one of the major reasons why childhood cancer, particularly ALL, remains significant health burden in Indonesia. And the geographical situation in Indonesia also bring its own challenges because it is trouble with more than 17,000 islands that we have. It is a challenge to ensure timely access for referral, diagnosis, and treatment, especially in remote provinces that lack specialized oncology service. And throughout the country, the burden of disease is as follow. The data showed around 4 of 100,000 children diagnosed with ALL. And then data from 2023, there are more than 4,000 cases with ALL in children, and our data from multi-center registry, the IP card from 12 centers, recorded around 750 new cases in 2024. And throughout the country, there are only 75 pediatric hemato-oncologists consultant and mostly distributed in referral hospital. The treatment was using the national protocol. Currently, we have 2018 and 2024 protocol, which was based on the national guideline. This picture, I want to show that there are provincial gaps in the referral centers. From 38 provinces, there are only 21 provinces that have their own referral centers, and most are located in Java or around Java Island. And there are still around 17 provinces that still do not have their own referral center. But thankfully, with the support of the Ministry of Health, the number of these hospitals are increasing, and ALL is also managed in many regional and private hospitals around the country. And this is the analysis of pediatric ALL service in Indonesia. We have several strengths and opportunities we want to highlight. The first is that with the model of service delivery, we call it pengampuan or mentorship program, where each referral hospital has several hospitals under their mentorship that enable knowledge transfers, patient referral, and capacity building. And also the ALL is covered under the universal health coverage, and the multi-center hospital-based cancer registry that is already developed and still expanded. And then we have our PHO working group, and with the launch last year, we launched the Pediatric National Cancer Control Plan, which was acknowledged by the MOH. And there are a lot of opportunities that we are very thankful. We have this regional, international, and multi-sectoral collaboration in trials, knowledge transfers, drug access, and donation, such as from SIOP, Senjut Global, FIFA, ACT program, Princess Maxima, and also WHO CRCCN. And also the MOH provide this learning modules platform, which enables us to share and increase awareness, especially to healthcare personnel in rural areas, and also they provide scholarship for fellowship and training, including in hemato-oncology. But there are a lot of weaknesses and threats, especially with the limited access to basic diagnosis and also advanced diagnostic, including immunophenotyping, MRD, molecular and cytogenetic, and also the non-sustainable in the recommended medicine. There are several periods of a shortage in Leones and 6MP, and limited to non-availability of advanced treatment. We have very limited stem cell transplantation center. There are only 2 centers throughout the country that already perform this with limited number of patients, and because of the coverage too, and no CAR-T at the time, and no immunotherapy. And there is still a lack in the policy and commitment from the government, and the low in awareness and cultural barriers. And I would like to share a little bit about the National Health Insurance. We call it BPJS. And this BPJS is actually playing a key role in enabling so many children can access the treatment free of charge. So the systems is using the INA-CBG case-based group with fixed reimbursement based on the hospital level, case severity, and type of chemo or the setting, like whether you get it inpatient setting or outpatient setting. And the diagnostic coverage is around 700 to 1,800 US dollar, and the treatment coverage per admission was around 180 to 700 US dollar. And the advantage of this system is, of course, families do not have to pay at all. So every child can theoretically access the treatment regardless of their socioeconomic status. But the limitation is some hospitals, sometimes we can only provide substandard service due to the financial constraint, and the waiting list for higher covered ward admission can delay the care. And in terms of availability, the phenotyping, BCRA, BL, MRD is very limited. Some hospitals need to send the samples, and it took days to get the result back, so it delayed the care. And for molecular cytogenetic, it is not provided in service care, but mainly only for research. And here I want to show our journey with the national protocol. It was initiated around 1970s with adapting the earlier version of COM, ALL, and Dutch protocol. And we have our first true Indonesian national protocol in 2000. Known as Wijaya Kusuma Protocol. This was acknowledged by SIOP at that time. And since then, Indonesia has implemented multiple cycles of protocol renew, roughly every 3 to 5 years. And this is the result from the very first, the 20,000, with still high relapse rate, high dropout, and delay of treatment, but less toxicity compared to the previous one. And then in 2006, the survival range around 49 to 69. With comparison in DEXA and prednisone group. And next in 2013, there is no improvement in survival. It is still remain unsatisfactory. And then in 2016, there is a little improvement, but this is only the result from a single center. We haven't had a result from national data. And then in 2018, there was a new protocol based on the consensus of the group with varied result. And in 2024, we launched our latest national protocol. And up until now, the registry, including from the 7 hospitals, with more than 380 patients. The change is the addition of the reinduction block, and then we increase the dose for the MTX in high risk group and standard group, and with no pause in 6MP. And early results showed improvement in survival trends and quite manageable toxicity, although this data is still being analyzed. So from all the journey in the protocol, there are several important lessons that we want to highlight. The first one is the outcomes depends on more than the protocol itself. So it is the supportive care, the referral, the early diagnosis that matters more. And then for us in LMIC, and then number two, the monitoring and data registries are our most powerful tools. So we need to invest in them very seriously. And then the hospital resources level must guide the implementation because one size does not fit all. And collaboration with expert can accelerate the progress and also the knowledge transfers. And then we need to always advocate to the policymakers to reduce the system barriers and to conduct a thorough analysis and the review findings for continuous improvement. And this is our future direction and several initiatives and efforts that is being already established and being planned. We have our guideline, the NCCP and the national protocol, and then collaboration, the international partnership, and then we are doing our latest service mapping to understand better the challenge and the situation. And then we already developed the handbook for referral and detection. And for the advocacy, we try to engage many cancer foundation and the MOH for National Cancer Registry in the future. And we're still continue the monitoring and evaluation for the latest protocol. And our plans are to implement this detection and referral through an online communication system and to have our established patient navigator program supported by the MOH and the Cancer Foundation. And one of the main barrier is to have agreement or discussion with the working group with the national insurance in terms of the reimbursement scheme with and identify the key gaps in essential diagnostic and the treatment that patient with ALL needs, and to enforce the national regimens tailored for the institutional capacity and to leveraging global resources so that in the future we can have access to advanced ALL treatment. I think that's all for my sharing. Thank you so much for your attention.
Thank you so much, Dr. Ilmana, for your clear and insightful presentation. Your overview of Indonesia's challenges, progress, and future plans, including early detection efforts and patient navigation, was extremely valuable. We now have around 10 minutes for Q&A and discussion. I invite all of the participants to submit questions through the Q&A box. Or if you're comfortable, you could turn on your microphone and ask a question. We will begin with a few questions for our speakers. But first, does anyone has any questions?
I have I have a question to both speakers, Vietnamese and the Indonesian group. I think they are, I saw Vietnamese has a slightly different treatment regimen between the location. And also Indonesia is trying to become national studies. I feel like, as a country or even regions to get, united or, resource-based approach. But first in the Vietnam, how difficult to develop the common trial, and then what kind of effort has been done, and in the Indonesia? Just my question.
Dr. Hiroto, because in Vietnam, each hospital is dependent hospital. So, and some hospital they use frank protocol, and when we move to another protocol, it's difficult. And it's also depend on, because we don't have your good direction from Ministry of Health. So each hospital, each director can have a right to select protocol. So until now, it's difficult. But we also we have a Vietnam Pediatric Oncology Association. So at the meeting, we also want to have a unified protocol. And now most of my hospital use CORI protocol. The other hospital previous they use Frank protocol, but now they also some of patients they also use CORI protocol. So we hope in the near future we can have a unified protocol. Yeah, thank you.
That, can I add some answers to that, Prof. Hiroto?
Yes, please.
Yeah. Thank you. For Indonesia, probably it is easier because with one unified protocol, it was easier for us to advocate to the ministry because they tend to want to have like how is the protocol? How many resources that you need? In terms of money, how much do you need for one patient, etc. And for us as the physician, personally, I think maybe it would be good if there are different capacities in each hospital, then one maybe most advanced hospital can have all the diagnosis and the treatment. And I think that is what the ministry in Indonesia aimed. That's why they appoint one of the hospital as the National Cancer Hospital. So the other below that National Cancer Hospital can do in standard, but maybe we don't need that complete because we in terms of resources and money, we need to prioritize and we need to take that into consideration. But for us, up until now, we promote the colleague in the working group to use the same protocol, so it's easier for us to follow and to evaluate and to have next improvement. Thank you.
Thank you. Dr. Church has a question.
No, you hear me?
Slightly difficult.
I am so sorry. I will put it in the chat.
And we can hear now.
Oh, you can? Okay. So, your question with regard to overall protocol development, these national protocols, is a large undertaking, as other speakers have mentioned. I am very interested in whether or not some of the new technologies to enhance the current protocols in the countries is potentially of benefit. The nanopore technology, we know that there's been work with regard to a lot of these genetic markers, and even the experience we have with Blino in Southeast Asia. So being able to make these little enhancements on the current protocols to be able to provide some significant changes. Maybe not.
I can mention about this. This is I also included in my slide, and the nanopore technology is very good. They can identify AML, B cell leukemia, T cell leukemia. That's we don't need flow cytometry if you use it, and also that can identify by RNA expression profile, and then can divide ALL to several subgroups, and then AML to several subgroups. So we don't need a cytogenetics, a FISH or RT-PCR. If this test is done, it decreases a lot of possibilities. So at least we think I'm still microscope to confirm this is the leukemia, but once confirmed to leukemia, it covers flow cytometry and cytogenetics, which is very good if it can be expanded. I think Sally is now in Memphis, but she answered yes, so she agrees with me. I'm happy.
We
And then
would love to have it, Prof.
Yeah, I think we should expand on top of this immunotherapy. Gradually, we hope we can expand it, and then you don't have to give a strong chemotherapy. I don't think it's a frog leap. However, this frog leap may be better for you. You don't have to now you have this therapy. You don't have to go this big therapy. You can go to flop jump to immunotherapy. You don't have to give a intensive therapy. That might be the future in the LMICs. And you don't have to repeat the history of the high income country that I showed in my slide. And a new therapy hopefully become available. New diagnose strategy hopefully become available. And then, we need to collaborate and hopefully we get some funding and it become very cheap and then can be applied to the patient in the LMICs. That's our hope. And that I hope that happens.
I do have a question for Dr. Hiroto. So, you demonstrated remarkable survival improvements over the last decades in your presentation. And what lessons from high-income settings can be realistically adapted to the lower middle-income countries to accelerate the survival gains?
Yeah, so the high-income country were able to intensify the chemotherapy and supportive care and a lot of technology for diagnosis. That improved, but I don't think this is needed. We have now new therapy available, so the intensive chemotherapy good risk classification made a survival 94, but looks like hopefully immunotherapy bring higher than historical. So you don't have to go this intensified therapy. You just go to leap. Just Sari said, big frog leap. I think this can be done, and then it should be considered in the LMIC. That's our hope to happen. Dr. Lan has comment.
Thank you so much, Dr. Hiroto. I see a hand from Dr. Lan.
Thank you for the lecture from Dr. Hiroto. In our center, have a lot of patients have allergy with the aspinaza because we use the special product from Germany. Every week we have one or two patients have allergy, and then we after that we have a stop aspinate spectra, and then we don't have enough equinia replace for spectra, and do you have any advice for us for the patient maybe take more doxorubicin or take more any drug, because a lot of patients have a problem with the aspinate.
Yeah, this is a very important issue. The patient react to allergy because asparaginase is a non-human product. So many patients, maybe 20-30% eventually develop the native asparaginase allergies that deactivate allergies. That's a major issue. And then even peg asparaginase that can cause. So if you don't have anemia, possibility can be done is a desensitization. That can be done. And the interesting story is if you give immunotherapy before the asparaginase, that seems like significantly decrease asparaginase allergy. For example, if you give a blinatumomab earlier before asparaginase, looks like patient may not develop allergy to the asparaginase. So in the future, we may learn a lot of things. And that's why I'm hoping that these immunotherapy become available, and then that hopefully improved a lot of care in the current situation. That's hoping.
Thank you so much for the wonderful Q&A session. So I'm sadly this is coming to an end of the session. I would like to thank to all our speakers for their excellent contributions and to all participants for your thoughtful engagement throughout today's session. It has been wonderful. Today's discussions emphasize the importance of translating global evidence into context-appropriate and sustainable strategies that strengthen pediatric ALL care in resource-limited settings. On behalf of the SIOP Asia Education Session team, we really appreciate your participation and commitment. As this is our second session in the series, we warmly welcome your input as we continue to shape the upcoming webinars. My email has been shared in the Zoom chat. Please feel free to reach out directly with any suggestion for future webinar topics, and I will ensure they are forwarded to our team. And thank you everyone today again for joining us. We look forward to seeing you in the future SIOP Asia sessions.
Thank you very much, and you did a great job for moderate. Thank you.
Thank
Thank
you.
you, everyone.
Thank you so much.
Bye-bye.
Thank you. Bye-bye.
Bye.